Topic which is being given to me is osteoporosis. I try to, uh, though all of you know, uh, I will try to be as brief as possible because this is one of the most common disease the humankind is facing, especially in the aging population world, world around, not only in India, but many of the countries, as the aging is, because the life expectancy has gone up and the population is one of the most thing affected is the osteoporosis, as we call as low bone mass, and the bone structure is slightly changing because of the uh, density is become less, thereby there is a bone fragility is becoming more, and the tendency to become, getting fractures has become more, and that's the reason why the most of the people with the osteoporosis land in the orthopedician's hand with the fractures. So osteoporosis generally does not become clinically apparent until a fracture occurs. So that's how the patients come to the orthopedic fraternity. The most common sites of the fractures are the vertebrae, the proximal femur, and the distal forearms. And of course, no bone is exempt from the fractures in osteoporosis, but these are the few common bones which we encounter. And they suffer usually from the pain and the limited range of motion, and there will be a disability and deformity in the latter stages. Of course, the depression and the loss of self-esteem are the psychosocial symptoms which the patients encounter in these osteoporotic patients. That's why there is a increased risk of mortality and future fractures. This is in terms of the how much cost the people around the world. You see, the first one in India approximately in the US dollars, that is the figures they have given. And this has become a serious public health problem now worldwide. 1 in 3 women and 1 in 5 men over age 50 experience an osteoporotic fracture. A bone breaks due to osteoporosis every 3 seconds. It is second only to cardiovascular disease as a global healthcare problem. And in India, 1 in 8 males and 1 in 3 females over age of 50 are suffering from osteoporosis. And there is lower age of peak incidence by at least 10 to 20 years compared to Western countries. And this is the graphic figure. As the life expectancy is going up, the osteoporosis incidence is rising. And this expected population projection by 2050, how it is there. You can just see that one. And coming to the pathophysiology, you know that the bone homeostasis, how there will be bone remodeling will be there. One side there will be bone resorption, other side bone formation is there in a normal bone. But as the aging is going, when there is a estrogen deficiency, especially in female population, and with the other metabolic derangements, there is an increased osteoclastic activity one side, and there is a decreased osteoblastic activity other side, resulting in bone resorption, taking over the bone formation, resulting in the osteoporosis. This is the brief outline of the pathophysiology. And going into the causes, you know that there are many lifestyle factors which cause either directly or indirectly resulting in the osteoporosis, like alcohol abuse, and you know that the smoking, vitamin D insufficiency, when there is an inadequate physical activity, low calcium intake, high salt intake, excessive thinness, excessive vitamin A immobilization, and one side when there are causes like if you go, there are other examples, like if you take the genetic causes, diseases, you see that homocystinuria, hemochromatosis, And you know that osteogenesis imperfecta, we see osteoporosis and other diseases like Marfan syndrome. And the hypogonadal states where there is androgen insensitivity, when there is a premature menopause, if you see like in Turner syndrome, this osteoporosis is common. And other endocrine disorders, you know that the Cushing's disease and diabetes mellitus and the thyrotoxicosis, and the GIT disorders examples are there, and hematological disorders. There is a rheumatologic and autoimmune diseases. We see commonly encounter rheumatoid arthritis where you see commonly osteoporosis. And the miscellaneous diseases also in COPD and asthma, where there is a more intake of especially steroids, it results in also osteoporosis. And other medications, as I told, when there are intake of anticoagulants and anti-malignant drugs, also it results in the osteoporosis. So when how to diagnose? Diagnosis mainly clinically. We can diagnose by going into the history, the risk factors, which I enunciated already. All the risk factors, you can go into the history, the physical examination, and also the most important way of measuring or making a diagnosis is BMD assessment. And the vertebral imaging and other biochemical markers of bone turnover and other investigations of recent that CT, other modalities. You see, these are the physical examinations. Sometimes will reveal any occult fracture are there, and the posture, how an individual stands, and your palpatory things of going into the tenderness, all those things sometimes may show you that the patient may be having osteoporosis. But coming to the exact diagnosis, we go into the bone mineral density calculation. So WHO defines osteoporosis in terms of BMD. So the DEXA measurements of the hip and spine used to establish diagnosis of osteoporosis. And then normally, you know, the T-square is always the more than -1. If the bone density is no lower than 1 standard deviation below the mean peak bone mass. And the low bone mass or osteopenia, bone density, if it is between 1 and 2.5 standard deviation below the mean peak bone mass, that is T-square between -1 and -2.5, we call it osteopenia. And the established osteoporosis, when there is a bone density with the 2.5 standard deviation or more below the young normal mean, that is T-score less than -2.5. This is the right side, the one, the orange or the red mark below the -2.5 is a classical osteoporosis. So what are the indications for the BMD? Asking for a BMD testing is regardless of clinical risk factors. Usually if the woman aged more than 65 years or the men aged more than 70 years. Of course, this is not a standard line marker that to ask for that one. There are other factors also. As a clinician, we will be knowing how to order a BMD to whom. So with clinical risk factors for like young postmenopausal women, women in menopausal transition, so many aged between 50 and 69 with clinical risk factors that known that they are prone for fracture, we should ask for a BMD test. So adults who have fracture at or after age 50 also. So adults with conditions like rheumatoid arthritis are taking medications like steroids, as I told you, associated with then low bone mass or bone loss, should be asked for a BMD test. So bone mineral density sites measured are DXA of hip measured at femoral neck, Watt's triangle, then trochanter level, and intertrochanter region. These are around hip we measure. And in vertebrae, lumbar spine over L1, from L1 to L4 vertebral bodies also we ask for the bone mineral density. So something is the importance of T-score, Z-score. Usually we see into the T-score, but Z-score also we go into that one. Just the difference is that the T-score, patient's T-score is BMD value compared with that of control subject who are at their peak BMD. The Z-score is BMD value compared with that of persons matched of age and sex. So if this person's BMD you are testing, so with other persons comparable age and sex, if you compare, it goes into the Z score, measured by both or by DEXA only. So the vertebral fractures on vertebral imaging, the sign of impaired bone quality and strength you have to see, which is a strong predictor of new vertebral and other fractures. And there is a performed using is in lateral thoracic and lumbar spine X-rays, where there is a lateral vertebral fracture assessment using the DXA machine. The presence of a single vertebral fracture increases risk of subsequent fractures 5-fold. If you see one vertebral fracture with osteoporosis, you have to suspect that this patient may go again into vertebral fractures at other levels. And also there are associated risk of having fractures at hip and other places which I told initially are also increasing about 2 to 3-fold. So the indications for vertebral imaging, as I already told, there is no need to repeat, but the postmenopausal women and men aged 50 and older with specific risk factors like low trauma fracture during adult. With a trivial fall itself, patients sustain fracture many at other times. They come to us without having a major trauma, should suspect that there is an osteoporosis. When there is a historical height loss of 1.5 inches or more, when there is a prospective height loss of 0.8 inches or more, when there is a recent or ongoing long-term steroid treatment, you have to suspect that there is a risk of going into the fracture. So what are the biochemical markers of bone turnover? So bone, as I told earlier, that the bone remodeling occurs throughout the life. It's only in osteoporosis the osteoclastic activity goes up, that is a bone resorption, than the bone metabolism or osteoblastic activity. So the biochemical markers of bone remodeling which include are resorption markers like serum C telopeptide, CTX we call, and urinary N telopeptide or NTX. So formation markers like serum bone specific alkaline phosphatase, BSAP and osteocalcin. These are the some markers which nowadays in some specific designated centers only these tests are carried out. So evaluating biochemical markers of bone turnover predict the risk of fracture, rapidity of bone loss, the extent of fracture risk reduction after treatment. The magnitude of BMD increases with the treatment. So as the treatment you start, and when we go into the biochemical markers, with this one we can assess whether the treatment is giving fruitful results or the BMD is increasing or not. So this is a FRAX tool developed by WHO to evaluate fracture risk of patients. The algorithm gives a 10-year probability of fracture, like knowing what is the current age, the gender, what is his alcohol intake, what is the any parental history of hip fractures, or what is the BMD at the femoral neck, what is the bone mineral density at other level when there is a low BMA, and the intake of glucocorticoids or other associated diseases like rheumatoid arthritis or associated current smoking, as I enunciated in earlier thing, that what are the predicting factors or the risk factors. All these things have given a just questionnaire to see that what is the probability of the fractures, can be calculated in 10 years, how the fracture with the BMD, with all this chart, which I don't go into the details, but we can calculate the probability of the patient getting into the fracture with going into this table. So in the other bone densitometry technologies which I just briefed earlier, like CT based absorptiometry and the trabecular bone score, peripheral dual energy X-ray absorptiometry like PDXA. This is more more advanced than the DEXA BMD scan which we are going. Quantitative ultrasound densitometry, though not specific, but will give a rough idea of osteoporosis. So having diagnosed subjectively, objectively the osteoporosis, the management becomes a thing of a topic without going to many of the time. Just the patients come, we'll take an X-ray without going into the other BMDs and the intensity of this one, we just start treatment. What are the general recommendations and the pharmacological therapy? I just go because many of clinicians, we know, physicians know better than us, but still I'll just brief the adequate daily intake of calcium and vitamin D. And the recommended dose of 1000 milligrams per day of calcium to men aged about 50 to 70 years. 1200 milligrams per day of calcium to women aged more than 51 and men aged more than 71. And the controlled clinical trials show reduced fracture risk with combination of supplemental calcium and vitamin D. Now 800 to 1000 international units of vitamin D per day for adults aged 50 and older. These are all the general recommendations. And then vitamin D deficient individuals, because that's the reason why many other times we are asking for the vitamin D test also. What is the vitamin, especially we are going into the vitamin D3, what is the level, and then we are starting the vitamin D supplementation. High dose is followed by maintenance therapy. That's why 60 K we start and manage with the supplementation therapy. So other general recommendations are regular weight bearing and muscle strengthening. This is the most important thing which we have to advise to our lazy patients, most of us we encounter. The other precautions in fall prevention, especially suppose if the house you have got a slippery flooring, and you have to advise them be careful, because because we know that in osteoporosis a trivial fall is enough to sustain a fracture. So other habits should be avoided, like tobacco usage and alcohol intake. So population based strategies for prevention and treatment of osteoporosis. These are all in a tabular form, which I have told earlier have been enunciated here. So what is the pharmacological therapy? After going into the general recommendations, the postmenopausal women and men aged 50 and older presenting with following to be considered. What are those? Vertebral fracture, whether clinically or even asymptomatically, or hip fracture, or a hip DXE or lumbar spine with T-score less than minus 2.5. If there is a low bone mass, if 10-year probability of hip fracture is more than 3% based on Frack's algorithm, which I have given earlier. And all these things should suspect to start a pharmacological therapy. What are those things? Anti-resorptive medications like biphosphonates, which we commonly are prescribing, like alendronates, ibandronates, risedronates, zoledronic acid also we are prescribing as a step 3, level 3 actually. The calcitonin has also become one of the most used thing earlier days. The estrogen supplementation, the estrogen agonists and antagonists balancing, and the tissue selective estrogen complexes. All these things comes under anti-resorptive medications. What are the anabolic medications? As the level 4 treatment, which now most of us right away starting, many of our orthopedic surgeons or the clinicians or the even rheumatologists directly going straight away into the parathyroid hormones, that is PTH, the teriparatide. Many of the companies are coming out with this teriparatide as in a competitive field. So guidelines given by American Association for Clinical Endocrinologists how to choose the drugs to treat osteoporosis. As I briefly said, the first line agents are the alendronates or the zoledronic acid. The second line ad, ibandronate. The second or third line agent are raloxifene. The last line agent in the field of anti-resorptive therapies is calcitonin. But the patients with very high risk, very high fracture risk, or in whom biphosphonate therapy has failed, should be started with teriparatide, is giving very good results. And these are some of the newer agents. Denosumab, fully human monoclonal antibody, which inhibits osteoclastic mediated bone resorption. Where there is we are seeing the reduced incidence of fracture after 3 years of use. There is a gain in BMD after 10 years of therapy. These are many of the things are coming in the market. If you just go into the market is dumped with this all the medications of pharmacological medications for the osteoporosis. And the individualizing osteoporosis therapy, you can just, there is a chart we can, but more than all the things which are given here, it is our clinical sense and the judgment. And the individualize our treatment. Basing on our clinical sense and our experience, we have to individualize the osteoporosis therapy. Because in the market, don't be carried away by the, I shouldn't say, but by the companies which are coming and flooding in the market. But with our clinical acumen, with the real diagnostic modalities, and which is best suitable for that patient should be prescribed, and the patients will definitely be benefited with those. And other new agents like strontium products also promotes bone formation, and also this simultaneously inhibits the bone resorption. The evidence of after 3 years use, after 5 years use shows that there is a reduction of fracture extent. And long-term trials after 5 years demonstrate, as far as the strontium product is concerned, there is a gain in BMD, bone quality improvement, there is a reduction in risk of vertebral and non-vertebral. These are the things which future, after completing what is present, past, I am just giving 1, 2, 3 slides of this future treatment modalities of the osteoporosis. The open label extensions of strontium products for up to 8 to 10 years confirmed that there is a sustained efficacy, long-term safety, high compliance to the treatment. So pharmacological therapy, as I again told, there are some do's and don'ts, the precautions. You have to caution the patient the good and bad things, thereby patient is really benefited. And there are drugs on the horizon. Anti-sclerostin antibodies. These are the things, osteocyte-derived inhibitor of osteoblast action. There is an inhibition of sclerostin, the bone formation is promoted. So, romosozumab, which I have given earlier, like humanized monoclonal antibody, which inhibits the sclerostin and has dual effect of both promoting the bone formation one side, other side it inhibits the resorption. Therefore, BMD is increased in the sustainability of results are there, the compliance is good, and the future fracture incidents also have become less with this product. So this is always injected subcutaneously once a month. So in recent July 2006, biologic license application was submitted to FDA on these products. Probably there will be a significant improvements in hip bone strengths in population with high risk of fracture despite biphosphonate therapy, where in these type of products have got a future. The patients transitioning from oral biphosphonates to romosozumab showed consistent and significant gains in bone mass and estimated strength over teriparatide. So these are the future. So and also parathyroid related the PTHRP, the abaloparatide, which is a novel synthetic peptide analog of PTHRP, which has got an anabolic agent for postmenopausal osteoporosis, which is also self-administered like other PTH regularly, which we are using like daily subcutaneous injection. This is also submitted for FDA approval. So the drugs which are have shown have got an active phase of study, which is when compared to the teriparatide, this also reduced the major osteoporotic fractures by 55%. And there is an increased bone density to greater extent in hip region. So other like vertebral fractures, lumbar spine level also there is a increased bone density has been shown and published. The other horizons like cathepsin K inhibitors, which has got a major osteoclast-derived proteolytic enzyme in bone, which degrades type 1 collagen and other bone matrix proteins. This also demonstrates that the CAT-K inhibition also increases the bone mass, so which improves the bone microarchitecture and strength, which usually we see that the architecture is disturbed. There is a disturbed trabeculae in osteoporosis. So this inhibition of CAT-K will always improve the bone microarchitecture, and thereby the strength of bone is improved. So these are all other new drugs which are coming out, and there is a, as of September 2016, further developments on odonocatib, that is the CAT-K inhibitor, which is introduction of this one has stopped due to risk of stroke. This is one of the study. Probably they have to evaluate further to lessen this risk. So to conclude, the osteoporosis is a condition associated with significant morbidity and mortality. More than mortality, we encountered morbidity. Morbidity in terms of the patient's bedriddenness, in terms of the financial calculations which I have tabulated, how much exchequer is being spent on the government side and also from the public or in the private side. The last decade has witnessed a veritable revolution in osteoporosis diagnosis and therapeutics. The much success achieved has been due to enhanced understanding of basic bone biology. The bone density remains most valid and reliable measure of fracture risk. So the FRAC's other new imaging approaches help bone health evaluation and identify fractures earlier. So currently number of medications are available for management of osteoporosis. Each drug possesses specific advantages and side effects. Like biphosphonates have been mainstay of osteoporosis therapy, but questions exist about very long-term safety. Biphosphonates need to be taken on an empty stomach. You know that staying upright and delaying food for 1 hour. Teriparatide be given as a daily subcutaneous injection and used for a defined period of time. Relaxafen increases menopausal hot flashes and risk for deep vein thrombosis and embolism. So there is need for drugs that could, with high safety, increase bone mass, improve biomechanics, and reduce fracture risk more than do existing products, while giving long-lasting benefits even if treatment is stopped. That should be our goal, of course. New and potentially highly effective agents may offer novel therapeutic tools to counteract osteoporosis epidemic. Thank you very much for your kind, nice hearing patience. Thank you very much.